Good morning, everybody. My name is Martin Zwaans. I'm an interventional imager from the St. Antonius Hospital in Nieuwegein. And it's my pleasure to welcome you to this masterclass trick valve. And it's my honor to moderate this morning session together with my friend and colleague Marta Sitjes from Hospital Clínic in Barcelona. And in the CAT lab, we have an excellent team of interventionals standing by to show you a live case of a trick valve. So this is Xavi Freksha and Omar Abdul Jawad. And I give the word to them to explain what we're going to do and give you a little bit more details about the case we're going to implant. Xavi.
Okay, thanks, Martin. So as you said, it's a pleasure for us just to be sharing this case with all of you. You presented part of the team. Apart from Omar and Marta, we have also, our nurse, like Monse, Danny Cano was outside, Guillermo, the technician, and then from anesthesia, we have Maria Jose Carretero and Victor Calatrava, okay? So without any more delays, I think that we can, just start with the case. Actually, what we're gonna do is just present, the rationale, like the clinical history, then we will move on to more technical aspects, and then we will show the echo. And then after that, we will start right, from the beginning. So, like Marta will, show, this algorithm that we use for deciding patients with TR. So Marta.
Thank you very much, Xavi. Thank you, Martin. It's a pleasure to welcome you, everybody here in Hospital Clínic. So we will present you the clinical case. Can you show me the next slide, please? So this is a 72-year-old male who was a previous smoker. He had received in 1987 mitral valve replacement. He is wearing a mechanical single disc Bior valve. And of course, he's anti-coumarin treatment. He has chronic persistent atrial fibrillation, and he has a little bit of anemia secondary to iron deficiency. His functional status currently is New York Heart Association class 3, and he comes to our consultation referring asthenia and showing signs of right heart failure with clear edema in the legs until the knees, also ascites, and also his blood pressure is 120, 80 millimeters of mercury. He shows his these signs of right heart failure despite he's receiving intensive treatment with diuretics, currently receiving 120 milligrams per day of furosemide, also dapagliflozin, and also 50 milligrams per day of eplerenone. Next slide, please. This is his ECG, where you can see he has atrial fibrillation with a wide QRS, 150 millisecond, with RBBB morphology. Next slide, please. A little bit anemic, as said before. Hemoglobin is 10.5 grams per deciliter. Her renal function is, his renal function, is preserved, 55 mL minute. And in the right heart cath, there was a mean atrial pressure of 21, and pulmonary artery pressure was, was within limit normal. These are the figures for systolic, diastolic, and mean pressures of the pulmonary artery. Next slide, please. This was the preoperative echocardiography. I will focus on this transgastric view, which mainly summarizes the findings of this patient that had severe tricuspid regurgitation. Can you go to the next slide and we'll go back to this one? No, it's okay, the previous one, sorry.
Back one
more, please. One more back. Okay, this one. So as you can see, this is a short axis transgastric view where you can see this tricuspid valve, which is really a tricuspid valve with a posterior leaflet in the upper part of the left panel, and the septal leaflet on the. Let me see if I can. No, we don't have a laser. No. Sorry. Okay, so you see that the cut is made immediately at the tips of the leaflets, and you can see that there is a large gap that at that moment was measured 10 millimeters maximum width of the gap at the, particularly between the anterior and the septal leaflet. of the tricuspid valve. There was normal function of the mitral valve prosthesis with a leak of the perivalvular leak, which was mild, and we decided that it was not playing a role in the symptoms of the patient, and also on the signs, on the clinical signs, which was predominantly right heart failure. I forgot to mention that the pulmonary capillary pressure was 19 at the moment of the right heart catheterization also. So next slide. So the patient was also studied with CT according to our algorithm that I will discuss, and also screened for a potential percutaneous annuloplasty therapy. And this CT study depicted that the right coronary artery was close to the annulus in a quite large area if we had planned for percutaneous annuloplasty. So there was a high risk also of involving the right coronary artery in this percutaneous annuloplasty procedure. Next slide. So to summarize, with left ventricular ejection fraction was preserved. There was this mild perivalvular mitral leak. The right ventricular was ventricle was dilated with moderately dysfunctional right ventricle, and there was a large gap in the tricuspid valve with massive tricuspid regurgitation. CT scan confirmed this dilatation of the right ventricle. Ejection fraction of the right ventricle was estimated at 40%, and it was depicted not optimal for annuloplasty device, percutaneous annuloplasty device. So this is a little bit what we wanted to share with you. The algorithm that we are more or less following when we approach a patient with secondary or functional tricuspid regurgitation. First of all, we evaluate these patients from the risk of these patients to undergo potential surgery. Also very important, we evaluate frailty in these patients. This patient was 72-year-old, chronic heart valve disease with very advanced stages of right heart failure. So we thought this was a high risk patient because of his frailty and his surgical risk, also because of previous surgery. Then we look at the anatomy. As you can follow on the right side of the slide, we thought that the anatomy for repair in this patient was cumbersome because there was a large gap. Also, there was, and we will show you later on the echo, there was tethering of particularly the septal leaflet. So we thought it was not also, a CT also depicted that it was not suitable for percutaneous annuloplasty. So we thought that the patient had not a real optimal anatomy for repair. So in these cases, we approach these patients for a transcatheter valve replacement of the tricuspid valve. At this point, we have two options, but currently with the largest experience and what we have available in Europe is heterotopic valve implantation with cabal valve implantation, and this is what we decided for these patients. This is more or less the algorithm we follow here. This is why in all of them we perform echo, CT scan, and right heart catheterization to have the whole picture. I don't know, Xavier or Omar, if you want to comment more on this.
Well, I think, yeah, I think that it's very, like illustrative, and actually it's something that I think that, like all these three tests, gives, as you said, like the overall picture. So I think that maybe we move on, like with the case,
Yes,
just to...
we can,
next.
Yes, this is the for the tric valve patient selection. Obviously, patient selection is based in clinical, anatomic, and hemodynamic characteristics. These are the characteristics for Tricus Euro trial. Obviously, patient has to have heart failure, as we explained before, and any of the left side valvular heart disease have to be treated before. One of the for the selection that we have learned that the patients with severe renal failure, advanced renal failure, should be discarded for this therapy. Under a hemodynamic perspective, we need to have a high pressure in the right sides with a B wave that at least have to be around 15, and also with without severe pulmonary pressure, as we will show you. And also the right ventricular function, in this case it's a moderate depressed, but we have done cases even with low TAPSE, and we touch around 9, 10. Maybe we can precondition the patient with some drugs for the procedure, as we will explain later. Next slide, please. For the anatomical selection, Trick valve device is a device specifically designed for the anatomy of the vena cava. It consists in two valves, one for the superior vena cava and another for the inferior vena cava. In the right, in the right, you can see the superior vena cava prosthesis that has a belly that has a lot of radial force in the center, and it's a very important point because this is for attach the system into the vein wall, and the superior prosthesis have also a long skirt to prevent the paravalvular leak. In contrast, for the inferior vena cava prosthesis, the skirt is short, around 20 millimeters, just to prevent any hepatic vein occlusion. Okay, next slide, please.
Següent.
Next slide, please.
Següent, diapositiva.
Diapositiva, sisplau.
Ara ho hem sentit. Okay.
Well, we can
Now.
here is one of the advantages of this therapy is that we can plan all the procedure according with the CT images. So CT scan is really important for this technique, not only for the sizing but also for the procedure and the technique that we are going to do. And the more important marks are the diameters of the superior vena cava at the level of the innominate, at the level of the pulmonary artery, and in the transition in the junction between the right atrium and superior vena cava. And it's very important to measure the distance between the pulmonary artery and the innominate. This distance should be higher than 35. Otherwise, we have to implant the superior prosthesis higher than in the innominate, and there is a risk of occlusion of the innominate. So for this case, we choose a 25 millimeters prosthesis. Next slide, please. And for the inferior vena cava, it's also important that the diameters at the level of the transition, at the level of the hepatic veins, and also it's very important the distance between the suprahepatic vein and the transition, the junction between inferior vena cava and right atrium. If this distance is long, this will help us to attach better the inferior prosthesis. So next slide, please. For the planning for this patient, because a patient has a moderate right ventricular dysfunction, we precondition the patient with levosimendan. We get the 3-axis right femoral for the device, and 2 femoral, 5 French and 7 French for the pigtail, for control, and swan guns. Swan guns is very important. We place the swan guns in the pulmonary artery just to swan guns serve as a marker what is the pulmonary artery. Just remember that the belly part of the prosthesis has to be in a higher position than the pulmonary artery. So swan guns is helping for that. We are doing T imaging, as Marta, Dr. Asic explained you. Patient is under general anesthesia, and we choose 25 millimeters for the superior vena cava prosthesis and 35 for the inferior vena cava prosthesis.
Okay, Omar.
That's all.
Yeah,
So,
thanks. Basically, just to let you know, we also did a right heart catheterization, showing that the patient is quite dry, but still, the big wave, it's 24, 25. The capilla, like the wedge, it's around 17, 18, and there's no pulmonary hypertension. So now we're gonna advance, but
maybe
Marta,
we can show
sure.
Can
you podeu ensenyar polígraf gran? So now you will see now the big wave polygraph gran.
So this is the shape of at the level of the superior vena cava. You can see it's in in a big wave of 25, more or less, with a morphology that reminds us a ventricular shape of the curve.
Yeah.
Okay.
So now we're going to advance the valve and Marta will show you the echo. Tornem al general, pantalla general.
Maybe, Xavi, can I ask you a short question before you start the implant or not?
Yes, yeah, sure.
Sure. Just maybe it's good for the people to know, but what is your standard workup for these kind of patients? Is it always you doing all these patients immediately a CT or just wait for the TE? And if not suitable for clip or whatever, you do the CT, always right heart cath? What's your standard workup for these kind of patients?
Well, maybe Marta will, like just also give her opinion. I think that we like, always to evaluate not only the option to have like a TE therapy, but also annuloplasty. Especially, in patients with functional TR, that actually, the mechanism is dilation of the annulus. So in a sense, we think that the annuloplasty would have, like a lot of sense. So it doesn't mean that if it's an easy anatomy, we will go for the annuloplasty, but we like just to have, like just the evaluation, not for just trick valve in this case, but just to have the whole picture. Of course, there are exceptions. If the patient has renal insufficiency, if there is a risk, like with one of these tests, so we're not gonna do it and we're gonna skip. But in general, we like just to evaluate, like these two anatomical repair options, for all patients.
Okay, and maybe as well, maybe good for the audience, maybe you can explain a little bit about the concept of the trick valve before you do the implantation. What's the idea? Because it's a little bit different instead of fixing the valve. It's a different concept. So maybe you can explain a little bit what the idea behind the valve is.
Well, that's actually a very good question. And because sometimes, like it's hard just to understand the mechanism. But here, like basically, well, as you understand it, just to put like a tabby, like a valve, with a stent, mounted in a stent in the superior cava and inferior cava. So the objective with that, it's in a sense, like just abandon the tricuspid valve and, put, the stop put, like just the coaptation at the level of the cavas. With this, you don't have to worry about the anatomy of the tricuspid valve, meaning that if the patient have a pacemaker,
I think we lost connection. I think in the meantime, we have to reconnect with the cath lab again. Let's see. Unfortunately, we have to wait to reconnect to the cath lab again. Maybe to finish off a little bit what Xavi was explaining, I think indeed the concept about the trick valve is indeed is completely leaving the tricuspid valve alone, so you don't have to deal with annulus sizes, coaptation gaps, or these kind of things. So frequently these patients are a little bit beyond the normal edge-to-edge repair. So with Pascal or with a tri-clip device, these gaps frequently exceed above 8 maybe, and more. And the good thing about this, so even if you have these large coaptation gap with torrential TRs, you can abandon the valve and just prevent the backflow in the body by putting in the stent in the SVC and in the IVC. And this is giving a lot of symptom relief because the patients get rid of the ascites and get rid of the edema. So backflow is blocked. So I think also with the screening of these kind of patients, it's really important that we really see the backflow in the hepatic veins or these kind of things, or with the hemodynamic measurements in the cath lab as well. You check for these V waves because that's important to recognize the patients who can benefit from this therapy. The good thing also for this is that pacemaker lead, as Savi was already telling you, are really not an issue with the. I think we can go back to the cath lab now. Savi, can you hear us?
Yes.
Hello, are you
Good.
hearing us?
Good.
Okay.
We lost the connection, but
Oh, sorry.
yeah.
So
Happy you're
this
back.
is okay. So I don't know where you were lost, but this is a real-time imaging at this moment after intensive diuretic treatment. And as you can see, we are cutting from a longitudinal long axis view of the right ventricle and the tricuspid view in the transgastric plane, as you can see, and we are cutting the leaflets of the tricuspid valve exactly at the tip of them, where supposedly we should have the coaptation surface. And as you can see here, there is this large gap, exactly the same that we saw in the preoperative exam. So you can see here the septal leaflet, restricted motion here, anterior leaflet with some indentation here, and a small posterior leaflet, and a large gap here, even after intensive therapy of IV diuretics. As you can see, we have achieved a little bit of reduction of the gap with diuretics, but still it's large, ranging from 6 to 9 millimeters. So definitely a very large gap, confirming that probably it was not the best anatomy for a TR. Annuloplasty was also discarded. So this is why we are implanting the trick valve device.
Okay, thanks, Marta. So now Omar will show you, like basically, like the setup that, as you see, there is like these swan guns in the pulmonary artery. That means that the belly will be over this and then the pigtail. So
you can see here the pigtail in the brachiocephalic, in the right brachiocephalic. So showing you the distance between the innominate and the swan guns is quite large, it's quite long. So we have, I think, that around 50 millimeters according to CT scan images. So that means that we have enough space for place the belly here. So I think that the anatomy is straight. So I think that it can be a good candidate for this therapy. So we are going to start the deployment. The most important thing during the deployment is try to do the deployment as slow as possible in a high position, but as slow as possible, because we need to give time to the nitinol to expand and to attach to the vein wall. So we are going to start in this position. Maybe we can do a test here just to plan.
So again, I mean, the belly goes over the pulmonary, the swan guns, the pulmonary artery, and like the upper part of this belly has no skirt. So I mean, there's no problem, and you can see that here we have a lot of room. So we can start, like in a rapid way, as Omar is showing, like with his hands, and just to open.
So here,
and we're gonna start as we said, like here and fast, just to start, just to flare, like the superior part, and after that, we will slow down. So in this, like step, you can see always that like the valve tends to go up. So Omar, it's like pulling back all the time. Test, please. We are like super high, as you can see. We're going back again, like the belly needs to be over, the pulmonary artery. So there's a lot of room, and we want, just the upper part of this belly, like in the bifurcation. So now, as you can see here, like the superior part, it's kind of, like expanded. Test. I think that we can even go a little bit high, lower, no?
So when we have enough space here, we can do it. So here it starts to open the belly, so we have to go slow here now, very slow, very slow.
And now we're opening, like the belly. I mean, we're getting on, I think, open a little bit lower, because like otherwise.
Yes, the system tends to go up all the time, so we need to maintain tension during the deployment. So
Exactly. Now you can see that no, we will go like really slow to let the nitinol get contact, like with the
Yes,
walls.
please.
Okay, test.
And for this step, Savi, you're mainly focusing on the fluoroscopy, as of if is TE also giving you additional information?
I mean, in this, like part, actually, it's like fluoroscopy because, like Marta, as you can see, I mean, she's struggling. I mean, she's getting like very good images, but there's no marker. At the end, she's gonna see, how, adjust is the valve. But at this point, she cannot help. So like the superior and inferior is different, you will see, but the superior is mainly fluoro, okay? I think that we can just go ahead. I like it, test. I like it a lot, eh?
Yes, maybe even we can remove a
Yeah.
little bit the pigtail.
We'll remove. It's something that you need to remember. But I mean, I think that just to save contrast, I think that we're good to go, eh?
Yes, slow. Go slow, please. Sorry. I maintain tension, still maintaining tension until the belly part of the prosthesis is completely free.
I'm going slow.
Very slow. We have to give time to the nitinol to attach the vein. It's the only way to attach. There is no calcium here, so we have problems our enemy is the migration. So for avoiding any kind of migration, it's very important to be patient during the deployment. Okay.
You can see here very well, that the belly, like if you see, like just if you remember, like, and actually we can show you, here, you can, use the wires of the previous surgery, as a marker. So you can see that the upper wire, it's, like right in the middle of the bifurcation. So if you go back now, you can see perfectly that we have a lot of room here. So it's important also, because you're gonna face patients with renal insufficiency, to save as much contrast as possible, no? Like in this case, I mean, we're not gonna use more than that. So I think that it's very good.
Oh, sorry, Savi, did you ever use the fusion imaging like CT overlay because you already have the CT information available? Did you use that for this?
We haven't used it yet, but it's something that we definitely, like consider. We have like these brand new, like rooms now, and we will like getting used to all, like the novel features. And this is something, and actually it's like a setting that I think that it's very useful because actually it's not moving. So just to save contrast, like will be like really good. And that's a very good point, Martin. So you can see that I'm going slowly, very slowly. It's just a matter of patience. Like now it's like everybody would, like deploy it, but you have to be patient.
Yeah, you have to be patient.
Omar, it's pulling back because like, as we said, like the valve tends, just to go up. Like the belly, it's clearly, like over the pulmonary artery. And actually, like I think that it's getting good contact.
Yes.
We're really happy, like so far.
Yes. So the system can be retrievable until the 80% of the device is deployed. So if we don't like the position, we always can recapture and restart again. It's important to don't push, only pull back, and don't push during the deployment. If you are in a too low position, we have to recapture all the system and restart again in a higher position.
So now as you can see, we're almost, like just free. At some point, I will like go very slow, and you will see that like one of the anchors, like will jump. So then at this point, we will have to wait, like for release a little bit of tension and wait, like just for
I'm
1 minute.
Tension. Yes, and releasing there is 3 hooks. Once we release the first hook, we have to wait maybe 30 seconds, 1 minute until we release the second and the third.
Can you do a cine maybe to show? We will do a cine. So here, let's see if, like one of the hooks jumps.
Maybe a question from the audience. What kind of wire are you using at the moment?
Yes, this is important, very important. We are using an Landerquist wire. We place the Landerquist in the jugular. I feel that there's another hook. Okay.
Yeah.
So we put the Landerquist in the jugular, and we check if the jugular have enough space for the nose cone, because the nose cone now is inside the jugular, as you can see here. Okay, so it's important to use a stiff wire like Landerquist wire for the superior vena cava. For the inferior, depending of the anatomy, we can use the same wire in the same position, or we can change with another wire with
An inferior safari wire.
With the safari wire, exactly.
But basically, exactly, like this is something that it's learning in progress. Eh? I mean, we already wait 1 minute, so we can just like go ahead, you know, like with the next, you know, anchor. And
what is the point of no return, Safi? Is there a point of no return, or can you recapture?
Well, the point of no return is like around 90%. So when you start, you know, like to free the anchors, I mean, there's no return at this point. So now that it's completely free, I can like retrieve it completely, and we will, you know, like just undo all the tension. Okay, here, it's been like really nice. I mean, I think that for the markers, we don't even have just to do like a fluoro. Maybe we save contrast for the final part.
Yes.
And
yes,
now what we're gonna do is just to retrieve the nose cone. Yeah. Then we will put a safari wire in the right atrium. So we use the safari wire like in the past, like we were using like this Landerquist, but the cava, you know, tends to, you know, turn a little bit right towards the tricuspid valve. And, you know, like by using the Landerquist, you put a lot of tension to the left. No, so I think that the fact of having like a free wire inside the atrium, like releases a lot of tension to the system, and you know, like the final position is more predictable. So that's why we're using. So what we're gonna do, like now, it's like live. We're gonna retrieve. You know, like Omar will retrieve the the system, the nose cone. You have to go very slowly and careful. You can see that it's going very nice.
So answering your question about the no return point, once we have deployed the belly part, we can know if we are in a good position or not. If we don't like, we recapture the system. So we don't need to arrive until the 90%. If the 70% is deployed and we don't like, we can do it. So another important thing here before removing the system is to recapture all the system before remove. This is for avoiding any potential vascular complication. So what I am going to try to do now.
Sí, está bien. Ahora que está muy apretado.
Now.
It would be like an evolute, like it's just the same, or an avitor that you recapture the system. So
we let the system here just for hemostasia purposes until we have prepared
el introductor, okay?
The
safari wire and
also the inferior prosthesis. Maybe we can show how because this is a pre-mounted prosthesis. That is something really new and different from the other devices. Maybe Guillermo can show us how to prepare the valve. It's similar. It's the same for the superior and the inferior, and he's going to prepare the inferior valve. Can you focus, Guillermo?
Carla, sí, fem el focus a la taula que havíem dit. Okay, so Guillermo will prepare. You will see that it's really fast. Omar, in the meantime, maybe can show the inferior cava while we're like setting the cameras of Guillermo. La cava inferior. Okay.
Maybe one short question from the audience again. What size sheet are you using in the femoral vein?
For the device, it's a sheetless 27.5 French. On the right side, we are using a swan gun with 7 French and pigtail with 5 French.
So here also you can see, like the, like the injection that we need. Now what we have to do is just put the safari wire in the right atrium and then put the pigtail in the suprahepatic vein. So this will be our marker. Okay.
Yes.
And like Omar will do all this.
For the inferior vena cava deployment, TE can be very useful. Just to know how deep is the system into the right atrium. Just remember that the skirt of the inferior prosthesis is 20 millimeters, around 22 millimeters. So the system has not too much deep into the right atrium, just at least 10-15 millimeters, not more. And now,
Okay, now you
yes.
can see. Treu això i posa això, no? Potser, Montse, ajudes al... Jo vaig explicant. Okay, ajuda al Omar. Okay, so Guillermo, you can see here, like the inferior cava. It's as Omar said, like it's a big French, but like it's for the right side. It's vein. It's not a big deal, And as you can see, it comes pre-mounted. Si quieres que diga algo, you tell me.
It's just about flashing a few times.
It's like about flashing a few times and make sure that there's no air. But
When it's dry.
yeah, and the system you can see here, there is a cover that actually when you turn, like it's what opens, and probably like next generation will have like a marker to know where like this cover goes. But like it's very intuitive and very, very easy to prepare. Actually, Guillermo, how much it takes, if you need to go in a rush, how much?
3-4 minutes.
It's 3-4 minutes, just only 3-4 minutes of preparation. So meaning that, like you can have it prepared and actually, after a while, you don't need like a very special preparation, like it's something that you can, even if you have like an emergency and you have, the valves in the shelves, you can actually use it, So now he's stretching the plastic, to make sure that there's no air. Actually, like all about the air. No, it's basically to make sure that like they don't get any air. So this like in the cava, it's like a larger, like device, and you will see that now, like Marta will be able to show us much better, like the intervention. So in the meantime, Omar, it's like exchanging, like the wires and preparing everything, like for this setup. The idea is just to put, if you remember, Omar told you that there is like a 20 millimeter, 2 centimeters, 20 millimeter skirt, in order to avoid leaks, at the level of the suprahepatic veins, but not too long, because you don't want to occlude the suprahepatic veins. So the idea to get stability, that actually this would be more challenging, the inferior than the superior in general, is just to put 1 centimeter of the stent inside the right atrium, just to be in the safe side. So in this regard, and Marta will help us a lot. And actually, like I think that you can do this with sedation, and contrast, fusion, but at the end, when you start just to practice with this, or just doing this kind of procedure, I think that, like just for, like the comfort of the patient and everything, I think that it's good just to have it under general anesthesia and T, that it's helping. So Guillermo, so you're almost, so here, like now what we're doing is just try to, like this, actually there is like always like a gap here. So try to reduce this gap. And I think that we're almost set to go, no? 1 second. Okay, so can you show us again, like just the now, like the General Electric. Okay, so now like Marta, comes to really play the role. You can see Omar already that has put the Safari wire. So that actually at this point, just we can remove the swan guns, just to have, less, catheters inside.
That would be nice.
And then, like Omar will also put the pigtail in the suprahepatic vein. Sometimes, like this step can be challenging. Like before, he did it like really fast and without a wire. That it's not easy, yeah, this. But it's what it is. Okay. No, but aquí está bien. It's okay. It's just to have release. So now, if you can go back to the cine, Omar, and then show, what's gonna be, if you can explain just to the rest, what's gonna be your markers here.
Here you can see the inferior. I think that the enter can be the vertebral body with the last lead here.
Yeah.
I think that this probably is the entering of the junction between the right atrium and the inferior vena cava. We will check it with Marta also, with the echo.
Exactly. So here it's like we have like, we're lucky because we have like all this wire stuff, And you know, like since we have like all these wires, there's gonna be like probably a good marker. We repeat, you know, it has or needs to be 1 centimeter, you know, like around 1 centimeter over the junction of the cava and the right atrium. So here you can see that we have like a vertical wire that actually probably it's around, you know, like this spot. So this might be used as a marker, you know, just to have this kind of thing. And if not, we use like a bone marker, like a backbone, you know. So now we are already going up. You know, I'm controlling the Safari wire, and we will start a little bit.
Okay.
Yes.
Yes.
Little bit more.
Little bit more. Maybe we can start
Septum.
like here.
Però
So
estem posant el
with the
septum,
Safari wire, we feel more comfortable because there is always a smile, a slight basculation of the prosthesis during the deployment, and Safari wire help us to do this basculation of the prosthesis. So I think that you can start.
Yeah. So now, you know, like it's a little bit low. We will, you know, like use as we said this marker, you know, like vertical, you know, like a small wire, you know, like radio pack marker to start. And actually, I'm gonna start fast because now it makes no sense to go slow. Just again to flare, you know, the valve and keep contact, you know, like keep contact with the tissue, no? So first we need to open, you know, this. So here, you know, like we can go, as you can see with my hands, a little bit faster. So then, you know, like it will be very, very, very important just to go like really slowly once we get contact. So you can see here that, you know, like the valve, it's already flare. You can also see in echo that actually, like, I think that it's a good point. Tess, please. Actually, I like it.
I like it. Yeah, I like it. You can
This is like flare. It's now it's stopped to flare. So what the valve will do at this point is just to go up, because you know when it opens, you know, like it will go to the area where that has no, you know, like no tension. So that's why we need to go at this point, Omar. The movement is just to pull back to keep, you know, like the upper body of the valve, you know, like in the wire that we're set. And Marta will, you know, like confirm that, you know, everything is going well, and I will keep on, you know, like rotating. So here, you know, like again, like Omar needs to pull back to avoid this tension. And now that I can feel that the valve it's getting contact, you know, like with the tissue, now I'm going slow.
Maybe even with the respiratory, we can do an
Potser està un pelín
lower tidal
Siempre me
volume
parecen que están
for the
salidas,
deployment
¿no?
also.
And you can see, you know, like
Here
I'm just moving the
Vamos a verlo.
Safari wire to show you that there's no tension. Actually, the nose cone, it's dancing, which is good. Okay, Tess, please. Looks very good.
I
to me.
like, yeah. And geographically, I like. So maybe we, at this point, maybe we can check by echo.
Marta, can you?
Yeah, you're seeing here. So a little bit what we look is how much is within the atria, and also if there are leaks, no?
Yeah.
Well, at this point, I
Maybe-
don't know. Like
maybe
it's
at
still
this
not
point it's
open.
too early.
Yeah.
Yeah. Maybe not yet. Just to check if there is, how is the distance inside the maybe 10 millimeters, not more. I think that we are very good now. It looks like very good.
Yeah. Let's
Okay.
do a cine.
Yep.
Let's do a cine. Yes. Good. So far we've been using like 100 cc's of contrast. We're not gonna need like much more.
¿Puedes bajar el tidal?
You can do this with 30, 40 cc's of contrast, even with a fusion, maybe less. But like the patient had like almost a normal renal function, so we're not worried. But it's true that if the patient, you know, like some of these patients have renal insufficiency, you need to try to save as
avoid-
much.
Yes,
Yeah.
save as much. I think
Omar,
that
in the meantime, maybe, well, Martin, I don't know if the audience or you have like any questions. If not, we will-
Just got a question indeed. How Marta judges the distance in the atrium by TEE. I think you can see it on your images quite well. I think, and I think it also nicely showed that we're frequently talking about the bicava view, but the cava is not the vein, the vessel you can see on top, but it's coming in from the let's say 8 o'clock area. But how do you do your measurements, Marta?
So you have to see, so you have the coronary sinus here, and you have to rotate a little bit to see the inferior cava. Of course, when they put the wires inside, it's much easier to recognize. And here, as you saw, I was measuring the distance from the right atrium wall to the tip of the valve, let's say, okay? But of course, we should measure this in a three-dimensional way, because here I'm only measuring one, and that's a little bit the challenge. So here you have to use all the tools that you need, that you have, okay? So cutting in different views, okay? Also 3D may help if needed, but most of the times we don't need that. Also, it's very useful transthoracic echocardiography. So going for a subcostal view, sometimes in cases of doubt, it gives you the clue, okay? So it's very easy. The only problem is that you have to, of course, go into the operating field, and it's a little bit more difficult. Also, it's important, and I was struggling with this, to look also the other side, okay, of the valve, because I have been looking at this one and I am struggling a little bit to look for this other. Okay, what's your experience also, Martin? Any ideas?
No, I agree. I think I would use indeed a lot of X-plane to measure these kind of things. What sometimes is helpful, but indeed there's some shadowing at the moment. So indeed, moving the probe up and down to get rid of the shadow, and then maybe a 3D and with NPR could be helpful. So you can sort of rotate around your 3D NPRs and looking at the different sizes and distances. So, but I think indeed it's not always the easiest because we simply have some shadowing on TE.
Okay, so we are like getting progress. As you can see, like Omar is holding very well, the tension, like the tip of the prosthesis, still, like at this, like radiopec marker. I think that we can now do like a cine. So we will do a cine. And, I think that it's excellent. Like if Marta, maybe you can say that a little bit high, but it's actually not.
No,
I think that it's good. But Marta confirmed that, and actually, I think that it's a good position.
Yeah, maybe, not sure if you want to show a subcostal view. If we have
exactly, so I think that it's fine. It's one of the questions that I want just to ask you. If you don't see anything, it's good. No, the subcostal, like transthoracic, it could help. To the side. Tracheal pigtail, no. So we're gonna remove the pigtail, just to make sure that we're not trapping anything. And
one thing that we have done here is to decrease the tidal volume of the respiratory machine, just for helping to attach better the valve. There is less movement in the diaphragm now, so this can be useful sometimes.
And now at this point, like it comes, the critical point. Going back to your question, Martin, at this point, like it's fully retrievable. You can see here that, like the valve, it's, like I would say like 4 or 2/3 at least of the valve are in contact, with the cava. So we don't expect, like just a big jam, like you can always have, like something unexpected, but since we're using the Safari, this is something that has been, like reduced a lot. So I will keep on, like same speed, like really slow. And we will wait again, for the release of one of the 3 attachments. And after that, you can see now that it's almost, like release. And we need to wait a little bit more in the inferior cava. In the superior, it's around 1 minute, 1.5 minutes. In the inferior cava, we like just to wait 2 minutes per anchor. So maybe you can do like a cine now, just to see if it. No. It's fine. It's fine. Still, like, still we need some, like, churning.
Maybe in the meantime, a question from the audience again. They have if you can comment on the IVC valve skirt and the position and the relation to the hepatic veins, Osim. I think you already addressed this a little bit in the beginning, but maybe to get back to that again.
So basically, it's what we said. To have like now we will, like free, like Cine. 1 second, let me show you this, Martin, and then I go back to the question, because we will have then 2 minutes, to answer the question. You can see that it's almost there. We will do another. It's almost. Now,
Okay.
one. So now we wait 2 minutes. But it's very nice because actually it has not moved, and I think that this is very good news. So going back, I mean, we just like use the catheter, the pigtail in the suprahepatic vein to have, just like a physical marker, like a radiopaque marker. So in a sense, like the distance between the ostium of the suprahepatic vein and actually, the junction between the cava and the right atrium, it can vary, it can change. But in this case, was very close. So in a sense, we like, just to go, higher, of course, than the suprahepatic vein. You can see here, like that there is like a difference in the design of the valve where the skirt is. So in the upper part, 20 millimeters, you have a skirt. So that skirt is just to avoid any leakage, like at the junction, but to let it's short because you need to let, the suprahepatic vein flow go to the cava. Okay, so you would always look for, like a balance, go as much as possible, but, the maximum would be 1 centimeter, maybe a little bit more, like
maybe a little bit more. Most important is if you don't have a leak, paravalvular leak, it's enough. But sometimes there is a tendency to migrate a little bit into the right atrium. So for this reason, we recommend to be around 10 millimeters inside the right atrium, not much more. For challenging anatomies, maybe even in a lower position. So that's the secret of this technique is try to put as high as possible the superior prosthesis and as low as possible the inferior prosthesis.
And on the other hand, it's like a relatively new technique. So we all learning, like
yes, we are still in
it's
the
like
learning curve, all of us.
Learning progress. So it's just 2 minutes already. We're gonna cine and release the second attachment.
Okay, I think it's done.
Second release. Well, I'm not sure, but well, we will wait a little bit here. And actually, Marta now
finally
can actually start because like the upper part it's already open. Can start to assess the leakage if there is any leak. So I'm releasing like the tension from the nose cone. And actually you can see, that the B wave, like, because now, the pigtail, like the valve is still not open, completely, but the B wave went down, already.
Yes, the B wave is down. It's going down, and also the morphology, the shape of the curve have changed a lot. So another thing that we can check if there is a reversal flow in the suprahepatic veins also.
So what do you think, Marta?
It looks very good, no?
Yeah, I think so.
If you can explain us a little bit, what we're seeing.
So we have here 2 orthogonal views. So let's start from the beginning. So you have here, okay, let me show you. So you have here the inferior vena cava with the prosthesis. You see the margins of the prosthesis. You see the leaflets here. And we try to struggle to bring a little bit in the image, okay? And here, so what we look is that there is a good deployment and there is no perivalvular leaks, let's say, okay?
Good. Okay, that's great. So
also,
we will, sorry.
No, we can also use biplane orthogonal cuts, okay? So you see here on one plane and the 90 corresponding degrees here. So that's also useful. Of course, you lose a little bit of a spatial resolution, but it's good to look for more three-dimensionally to the valve, okay?
Very nice images, Marta.
Well, thank you, Martin.
In the meantime, like as you can see, you see the cine. We deployed the last one. The last one, like you see that it was still attached, although we end up, like, to the end of the rotation. But at the end, you can see like Omar rotated, and I think that it's already free. You can see here that now it's free, and you can see that it's completely free now.
Let's check it. Yes, I think so.
Let's check, with RAO or, like, yeah.
Yeah.
It's free.
So,
Good.
and you can see that the prosthesis didn't move. So it remains stable, completely stable in the position. So there is a bit basculation of the device during the deployment. This is I think that Safari wire is especially useful in anatomies, in challenging anatomies with big angulations between the inferior vena cava and the right atrium. In this case, we need that the prosthesis basculate during the deployment. With Langner quiz into jugular, sometimes it's challenging this. So we prefer the Safari wire if we have enough space for the Safari wire in the right atrium. If the right atrium is small, so it can be also dangerous with the Safari wire.
So now we need again, like just do the same operation. I'm gonna remove, like just the tension, and Omar will pull back, like the nose cone.
Perfect.
And like in the meantime, Martin, like, well, we're like actually, like, removing everything. What maybe we can discuss, because we have, I think that we only have like 5 minutes, no?
Mm-hmm. Maybe,
So maybe
there's some few
maybe or
questions
if
from
you-
the audience, so maybe I can ask you ask you that. So one of the questions is indeed for these challenging anatomies, and is it okay to partially cover the hepatic vein with the skirt, or is it something you immediately decline the patient on when you expect that on the CT?
Yes, we have to date we haven't any problem with occlusion of the suprahepatic vein. So I think that we can go in a low position, and usually the suprahepatic vein it's very large. The ostium is very large, and it's very strange that we occlude completely the suprahepatic ostium. So I think that the recommendation to go low in challenging anatomies, we have to keep consider that. So.
And somebody's asking, what is your strategy exchanging these valve catheters in order to avoid heavy bleeding? Is there a special trick? Since you have large bore catheters and these kind of things, it's frequently bleeding quite easily.
Yes, for the exchange, we put in a 22 French sheath for the exchange the wire during the procedure. And one thing, if you let the lander quiz and you don't want to change the wire, another option is just to maintain the superior prosthesis inside until we have ready the inferior prosthesis. And once we have ready the inferior, we remove the superior for hemostasia purposes.
Martin, I think that one of the burning questions, the important questions probably here, it's just to, like, just, espera, que això no va bé. Dóna'ns una guia... Sí, una teflonada normal. No, pues és normal, que pues una guia d'angioplastia. So it's about the questions, about the treatment after the intervention, okay?
Indeed.
So this is something, and Omar, like he's an expert with this. I think that now what you can expect when we, like wake up the patient, what do you expect?
Well, the very common sign is a shoulder pain. Okay, that it's very common, and sometimes it's intense. The pain it can be very intense, but usually it disappears in 24, 48 hours. But this is very common. We think that this is because there is a compression of the phrenic nerve by the inferior processes. So that is very common. And sometimes in 5% of the cases, pain can persist for 2-3 weeks. In that cases, we recommend gabapentin or something like that because it's a neuropathic pain in origin. So it's something similar what happened with laparoscopy interventions, etc. So that is very common. Another thing that we can expect, it's there is an acute and abrupt increase in the right and the ventricular pressures. So sometimes if the right ventricular function is very depressed, maybe we can have some like claudication of the right ventricle. For these cases, inotropic therapy can be very useful. Usually the procedure is very well tolerated hemodynamically, but in the following hours, maybe there is some hypotension or oliguria. In that cases, we recommend to start with inotropics more than with chorotherapy. because we need that the recover the function of the right ventricle. So I don't know if you want to ask.
No, well, you know, like I was let's remove this, you know, like we put the dilator, just we use proglides here. And what we're gonna do, if you like, it's just we will put, you know, the pigtail inside, you know, like as you can see, you know, in the polygraph, we will flash with suero, we will zero, and you'll see, you know, like, and now, you know, like just linking, you know, with one of the questions that, you know, what's, you know, like the mechanism, you know, of function, you know, of this system, we will see that now, you know, like the pressures in the right atrium go higher than before. And actually, you know, like it becomes more like a right ventricle, you know, this, now we are in the right atrium. So you can see here that we have like a big wave now of 50. Why? Because of course, you know, like we move the tricuspid valve, you know, from the tricuspid position to the cava position. And now Omar will pull back and you'll see.
Can you take this, please?
Polígraf gran, si us plau.
Polígraf gran. Grava.
This is important. Espera un momentet. No fluoro, polígraf. Now you can see very well, Martin. You can see very well, no? This?
Yep, excellent.
Okay, so this is inside the right atrium, and now Omar will pull back. Okay.
We are just recording that. This is not pulmonary, it's a right atrium. It's already ventricularized. And now we are in the inferior vena cava. So you can see the change in the morphology and in the shape of the curve, meaning that the valve is moving. It's doing his job. So I think that the concept here centered in the ventricularization of the right atrium, but usually these patients, that can be considered somewhat unphysiological, but usually this patient has already, the atrium is already ventricularized. So usually it's not functional. So what we do with this technique, we translate the tricuspid valve to the cava system. That's what the concept is.
Another thing that I already noticed is that actually you can see that, you know, the pressure is still high, you know, of course, you know, it's a huge change, but you need to wait some time, you know, because, you know, like the patient is still filled, you know, in the venous system. You need just to give some time. So you don't expect, you know, just like the pressures just to go from 25 to, I don't know, to 10, you know, immediately. It takes time. But the important thing is just to see, you know, to demonstrate this gradient, meaning that the valve and the system is working very well. So Marta, I don't know if you can show us maybe the right ventricle, and I think that if there are no more questions, Martin, you tell us, we'll.
Yeah,
you know,
there
like
are a
we'll
few, but I'm not sure if we have time. Maybe shortly can give a comment on the anti-thrombotic therapy afterwards and the diuretic.
Well, yeah, this patient, it's like usually we like to have these patients, you know, on, you know, like anticoagulation. This patient has a mechanical valve, of course, you know, he's gonna keep on, but we don't need to give any extra, you know, like medication antithrombotic. If the patient is taking oral anticoagulation, it's enough. And as you know, maybe 90% or 95% of the patients, you know, like with this disease have atrial fibrillation. So, you know, like almost all of them, you know, are already on oral anticoagulation. So it doesn't mean like a big change, you know, like in the discharge medication, but at the end, you know, like it's what it's need, you know, like oral anticoagulation.
Yes, under diuretic perspective, what we have seen is that we can reduce the diuretic dose after the procedure. That is we have to maintain, but we can reduce. That is important because this patient has 55 millimeters of renal function, of renal function. If we give high dose of diuretic, renal function will impair. So I think that if we can avoid to give high dose of diuretic in these patients, always it's helping the renal function, etc.
So Martin, any other questions?
Yeah, like I said, there are some few, but maybe one interesting, how does the device sizing work? Because we saw the CT, but how much oversizing, since there is no calcium or anything to anchor the device in?
Yes, this is a very interesting question. And usually we are doing between 20 to 30% oversizing, but it depends on the anatomy. because you can see the device is around 67 millimeters length, and anatomies can change a lot. But in the most important part, what I explained you before, it's a belly part for the superior and the superior part for the inferior. Maybe around 20–30% it's enough. If we do a big oversizing, especially in the inferior vena cava, we can expect more phrenic complications. So the patients that have important shoulder pain, even sometimes hemiparesia of the diaphragm, it was because there is a big oversizing in the inferior. So we have to balance the risk of migration against the risk of phrenic complications for the inferior.
Yeah. I think excellent. I think since we're already over time, I think we have to end up this masterclass. And I think indeed it was a masterclass. I would like to thank the operators for excellently and nicely educationally showed how to implant this trick valve. Marta, thank for moderating and the beautiful images we saw. And I don't know if you have some final words for the audience, Xavi and Omar.
Well, I
Thank you very
mean,
much.
thanks. It's been a pleasure, and it's actually we feel very happy because we could, like show and I think that provide all, like just the tips and tricks that we're using. We can, like we were able to discuss about the patient selection. So as you said, I think that it's feeling like very profitable, like just class, and we're so happy. And thanks, just to PNF, like for, of course, for organizing this and the invitation.
Thank you very much.
Xavi, maybe you can post on LinkedIn the follow-up of these patients, because everybody is probably curious what the follow-up of this patient will be.
Sure.
Of course.
Good. Thanks a lot, everybody, for attending, and
Bye.
have a
Thanks.
nice day. And thanks for the case. Bye-bye, guys.
Thank you.
Prolight.